So today we're discussing alcohol, and we just discussed the Cloninger and Jellinek classifications, which I forgot to record by then. But let's start with blood alcohol levels and their impact. So you essentially divide it into 0 to 30, 30 to 80, 80 to 200, 200 to 300, and more than 300 milligrams per deciliter. This is usually detectable by the blood alcohol levels, which are measured through either of the instrument or through a blood test. At 0 to 30, I want you to remember this thing, E and T. So which means thinking and psychomotor activity. Now there is slowness of thinking and reduction in psychomotor activity, which commences at 0 to 30 milligrams per deciliter. This is further aggravated at 30 to 80. Then at 80 to 200, remember CJ. What CJ means is coordination and judgment. So you will see a lack of coordination and impairment of judgment at 80 to 200. Then at 200 to 300, remember NSB. NSB stands for nystagmus, slurring, and blackouts. So remember nystagmus, slurring, and blackouts at 200 to 300. And then at more than 300, impairment of the vitals and probable death. So this is the blood alcohol level and its impact. Another important thing that you would want to remember is interpretation of audit scales. This is something that they ask a lot in the MCQs. So audit questionnaire is the questionnaire to check the dependence of alcohol. If it is less than 8, remember that there is no proper dependence or no proper conclusion that you've reached through. 8 to 15, you would say there is a brief dependence or it's borderline. More than 15 and 15 to 40 is proper classic dependence, right? Then withdrawal and complications are just fairly, I think, yes, remember that withdrawals are of 3 types: complicated, uncomplicated, and management. The way you differentiate between uncomplicated and complicated is, in complicated withdrawal, there will be delirium and there will be instability of vitals. Whereas in uncomplicated alcohol withdrawal, there will not be any delirium or incoordination or anything. There will be slowness of thinking, a little bit of confusion, some psychomotor retardation, some loss of inhibition, things like so. And management, remember Librium sliding scale, fixed dose Librium regimen. This is not something that they'll ask you in the paper B, but these are the different dose patterns which for Librium, which they might ask you in your essay type questions essentially. Besides that, long-term complications, obviously Korsakoff and Machefa-Bingami. What are the signs for it is something that they might ask you. What are anti-craving medications? They'll ask you, so can someone tell me what are the anti-craving medications for alcohol?
Camprosate and naltrexone.
Camprosate, naltrexone, and
Disulfiram, it's but anti-abuse, not anti-craving per
right.
se.
Disulfiram is anti-abuse. Disulfiram
Baclofen can be used.
What concept? Yeah. Disulfiram is based on the concept of aversion therapy. This is something that they might ask.
Yeah.
And just try and remember the mechanism of actions of each one of them as well. What is the mechanism of action of disulfiram?
Aldehyde dehydrogenase.
So does it increase the what do you say? It does not allow the alcohol to get converted from what to what essentially. It does not allow the alcohol to get converted from acetaldehyde to acetic acid. Okay, so with neurobiology of addiction, there are 2 main things that I'll try and cover. So I'll tell you the question that you asked, Nikhat, about how do you differentiate between stimulants and hallucinogens essentially, because that is something that a lot of these online modules will get you confused about. The way I differentiated it was, if there is just autonomic hyperactivity, then it is an issue with a stimulant. Whereas if they specifically tell you that there are hallucinations, then you go ahead and you mark a hallucinogen. It still might mess up, it still might cause issues with it, but more often than not, it will be the case. So they will ask you either cocaine or LSD. These are the 2 most commonly asked ones. So if it is just autonomic hyperactivity, go ahead and confidently mark cocaine. And if it is autonomic hyperactivity with hallucinations, then go ahead and mark LSD. What do we know so far is that genetic factors account for almost 50% of addiction, right? A particular genetic code, suppose it is the dopamine receptor, along with adverse environment, that is bad atmosphere, it will lead to damaged neurodevelopment. For example, the problem in the maturation of the prefrontal cortex. This will lead to behavioral traits. What are the behavioral traits? Well, experimenting and trying new things, initiation of substance, sentences like, let's try a cigarette, let's try things that are on the edge. If this happens at an early age, then there is an altered neurodevelopment or altered neurocircuitry, which leads to a long-term compulsive use or substance use disorder. Now, a 2009 paper showed association between beta 2, beta 3, alpha 4, alpha 5 subunits of nicotine receptors with cigarette smoking and dependence. Nicotine essentially reverses the hypofrontality in animal models of addiction and schizophrenia. So you have, this is why, it was hypothesized that nicotine or cigarette smoking might postpone dementia, so as to say, which has now obviously been refuted, and that's garbage. But there were theories that it makes the mind sharp and it postpones essentially dementia. This was the main basis of that hypothesis, that the hypofrontality, that is the frontal and the prefrontal cortex essentially not working as efficiently as you would like it to work, it is reversed by nicotine. So you might have seen a lot of schizophrenia patients who are addicted to nicotine because it helps them feel sharper, so as to say, because you find yourself dimming down when someone is diagnosed with schizophrenia, don't they? Now, the same gene mutation which leads to nicotine dependence also leads to hypofrontality in schizophrenia, therefore probably using it to treat themselves. Who is the most vulnerable at which age? Adolescents are the most vulnerable because the brain, not only being fully developed, it overvalues the reward and it undervalues the risk. Because it is not fully developed, what it will work on is it will work on Freud's pleasure principle, essentially. This is what I mean by this sentence. It will overvalue the reward and it will undervalue the risk. This is a very bad diagram of the outline of the brain, but essentially the ventral striatum is the reward center. It is not fully developed in teens, therefore more excited by reward than consequence. The prefrontal cortex, the function being planning and reasoning, it grows up to 25 years. Teens are immature and they are prone to high risk behavior, whereas adults are much more developed. The amygdala, it is the emotional core for passion, aggression, fear, impulse, and that's why teens are more impulsive, whereas adults they will rely less on this and more on the prefrontal cortex. Hippocampus, the hub of our memory and learning, it has tremendous learning curve in teens and therefore fully functional in adults, so that because it is in a developing stage in the teens, they are more vulnerable that way. And parietal lobe in teens doesn't process information as well as it is in adults. So children who have poor upbringing, they are found to have three major changes. Decreased gray matter volume specifically in the prefrontal cortex. So the inhibitory center does not develop as well as we would have liked it to. White matter reduction. Simple explanation is tracts carrying impulses from amygdala to prefrontal cortex are not very well developed, and reduction in alpha waves. Alpha waves are markers for coherence, restful, peaceful state of mind, isn't it? So how do you prevent substance use disorder? Early aggressive behavior needs to be channelized by self-regulation and skill training. Poor social skills need to be managed by social skills training. And exposure to stress needs to be managed by stress resilience training. And poverty essentially with social rehabilitation and jobs. So this is mainly from Stahl, right? So now, what is an endophenotype? Endophenotypes are, to simplify and put it into very simple terms, endophenotypes are symptoms that do not necessarily confirm a diagnosis of a disease, but they may be an element of the prodrome of the disease. Essentially, in simple terms, these are soft signs. And in people with schizophrenia, we see that they have smooth eye pursuit issues, or in people who have schizophrenia, we find that they have cognitive issues. These are not necessarily enough to diagnose a person as having schizophrenia, but these are things that you would still observe in patients. Similarly, you can list a list of 10-15 things for people who have depression, for OCD, which we might refer to as the personality being like that, but these are essentially endophenotypes. These are linked to specific brain circuits. and these are present transdiagnostically. So on whatever spectrum of the diagnosis that person is, they are present throughout. Does that make sense? I myself feel that I'm a little bit of an ADHD because I can't really sit and read a book. I need to either keep taking my notes or keep doing something. That does not mean that I'm ADHD, but I'm somewhere on the spectrum of being a little bit more attention deficit than people who are legit ADHD. So whatever, even though I might not have ADHD, I might have some characteristics which are on the spectrum of ADHD, so as to say. So addiction mainly revolves around impulsivity and compulsivity, right? A person is impulsive, which eventually gets converted into a compulsive behavior. So impulsivity is inability to stop the initiation of an action. Impulsivity is the inability to stop the initiation of an action, whereas compulsivity is the inability to terminate the action. Now, what is responsible for impulsivity? The ventral striatum, uh, specifically the nucleus accumbens, the reward center. Then you have the thalamus, which is your movement or motor, your ventromedial prefrontal cortex, which is mainly responsible for your emotions, and anterior cingulate gyrus, which is responsible for your motivation. For someone who's just starting off, this might seem a little bit overwhelming, but this is the language that you would speak after you've, gone deeper into it. Similar areas are again involved with the compulsivity thing as well, but you have thalamus doing a different thing. Orbitofrontal cortex, as you might know, is responsible for inhibition, so that is involved, and dorsal striatum is involved, that is caudate plus putamen. Now, impulsive acts such as drugs, gambling, obesity, they eventually get converted into compulsive acts because migration from the ventral to the dorsal loop takes place. What is the main thing? The main thing is cognitive inflexibility. So what is responsible for impulsivity? The ventromedial prefrontal cortex, anterior cingulate gyrus, ventral striatum, and thalamus. Whereas orbitofrontal cortex, dorsal striatum, and thalamus are responsible for compulsivity. So if you look at the broader picture, it's still prefrontal cortex, basal ganglia, thalamus. Prefrontal cortex, basal ganglia, thalamus. Right? Now, what is a habit? A habit is essentially a type of compulsion, right? But the type of compulsion which is triggered by an environmental stimuli, irrespective of current desirability of the response caused by compulsion. Essentially, a habit, how would you differentiate a habit from a compulsion? Is that a compulsion stays irrespective of currently do you desire doing it or not. So even if a person does not like drinking alcohol right now, he would still feel compulsive to have alcohol, and that is what you would call a compulsion. That is how it is different from a habit, right? It is associated with past experience of reward. When you do a goal directed behavior, you desire the consequence because that is your cognitive demand. You demand some sort of response or some sort of reward for yourself, because in the past it has been rewarded, biochemically it has been rewarded with such strong incentive, it becomes a compulsion now. So what is abuse? Self-administration of a drug in a culturally unapproved manner, causing adverse consequences. Now, a stimulation for the impulsivity cycle goes bottom up, whereas the inhibition cycle goes top down. You get a bottom up stimuli for impulsivity from the ventral striatum, which goes up to the prefrontal cortex, and compulsivity from the dorsal striatum, essentially from the basal ganglia to the prefrontal cortex, from a lower part to the upper part. But that is inhibited top down. So the inhibitory stimuli run top down from the prefrontal cortex to the basal ganglia. This fails in people who have addiction. This is not working all right. So the stimuli which keeps on coming, but then it is not neutralized by the inhibition that you and I would have. In this entire game, dorsolateral prefrontal cortex plays the role of cognition, hippocampus plays the role of memory, and amygdala plays the role of reward conditioning. So when substance consumption shifts from pleasure seeking to relief obtaining, there is a high risk. Remember these two words, pleasure seeking to relief obtaining. This is when there is a high risk. The first dose of any drug is the best one. It is the most reinforcing and it is without any penalty. Once it shifts from pleasure seeking to relief obtaining, involuntary response cannot be simply won over by motivation. Right? There is the final common pathway of reward, obviously, the mesolimbic dopamine release. This leads to intellectual accomplishments, athletic accomplishments, symphony, orgasm. All these are natural highs, natural ways. And what are the natural neurochemicals allowing this to happen? What is brain's own morphine or heroin? That is opioid. What is the endogenous opioid? Endorphins and enkephalin. What is brain's own marijuana? That is cannabis. That is anandamide, right? What is brain's own nicotine? Acetylcholine. And what is brain's own cocaine? Dopamine. So then you get highs which are natural or physiological. You have highs which are behavioral, and you have highs which are chemical highs. Who is prone to addiction? Who is pre-morbid, impulsive, or has a defective reward pathway are the people who are prone to addiction. Therapeutic use of stimulants targets the prefrontal cortex, whereas abuse will target the reward pathway. In the long run, it is not the reward of the drug, but the anticipation of the reward associated with seeking compulsive pathologies. As a habit develops, dopamine stimulation is not by substance, but by conditioned response or the trigger that it causes. 80% of people with Wernicke's will develop Korsakoff. Amphetamine is a stimulant drug which produces high with psychiatric symptoms common to and indistinguishable from schizophrenia. So this is how do I differentiate between a stimulant and a hallucinogen, isn't it? So if you have psychotic symptoms, you would want to go with amphetamine. If you have perceptual abnormalities, it is likely that it might be LSD or a hallucinogen. Then you obviously have PCP, which can cause bizarre postures, muscle breakdown, kidney damage, etc. Disulfiram has unpleasant side effect, flushing, headache, nausea, vomiting, palpitation. High dose of it can cause hypotension and collapse. Current prevalence of heroin use in UK is around 1%, male to female 2 to 1. Street heroin cost is around 80 pounds per gram. Average user consumes 0.25 to 0.2 grams per day. Untreated heroin withdrawal reaches peak at 32 to 72 hours, that is 4 to 6 days, and symptoms do not subside till 10 to 12 days. Benzodiazepines, 15% of those taking benzodiazepines for 1 to 5 months will develop dependence, and 40% of those taking benzodiazepines for 1 year will develop dependence. So ICE is another alternate name for amphetamines. In opioids, tolerance develops to nausea and vomiting, sedation, euphoria, respiratory depression. Minimum tolerance to constipation and meiosis. Risk of seizure in bupropion is around 1 in 1,000. And contraindications for the same, because bupropion is a commonly used medicine for substance use. So contraindications for bupropion are pregnancy, seizures, eating disorders, CNS tumors, breastfeeding, acute benzodiazepine or acute alcohol withdrawal. Then you have varenicline. Varenicline is a partial agonist at alpha-4 beta-2 nicotinic receptors with high affinity, much more effective than bupropion, and nausea, common adverse effect. Depression and suicidality can also be caused. Caffeine elevates the mood through increase in norepinephrine. This is an entirely different alcohol thing. So how is alcohol made? What is the procedure? What are the different chemicals? What are the concentrations? What is undistilled, distilled? What is country-made liquor? How do you calculate units of alcohol? What is low risk? So what are the types of alcohol? Essentially, you have methanol, propranolol, and ethyl alcohol or ethanol. You find methanol in wood, right? Furniture polish. And sometimes methanol is mixed with country-made liquor, which causes loss of vision and liver failure and everything that we see in developing countries. Then you have propranolol, which is spirit or rubbing alcohol, the one that we have in our sterilizers. And then you have ethyl alcohol or ethanol, which we use for consumption. In less amount, it is not toxic. Alcohol by volume. How do you calculate alcohol by volume? Number of ml of alcohol per 100 ml is alcohol by volume, right? Number of ml of alcohol per 100 ml of beverage is alcohol by volume. How is alcohol made? Alcohol is made by fermentation. What is fermentation? It is the use of bacteria or yeast. It converts essentially sugar, glucose into alcohol or ethanol. Wineries, they ferment grapes to make wine, whereas breweries, they ferment barley, wheat, and grains to make beer. So usually breweries they use barley, wheat, and grains to make beer, whereas wineries use grapes as the source of this sugar, which is eventually converted into alcohol. It goes through the process of distillation, converts already fermented substance into an even higher concentration. That is the process of distillation. It is already alcohol, but it is converted into a higher concentration of alcohol, example, liquor and spirits. So alcohol can be divided into distilled alcohols and undistilled alcohols. What are the undistilled ones? Beer is the most commonly consumed alcohol beverage. It is undistilled alcohol. It is the oldest alcoholic drink in history. Average beer has 4 to 6% of alcohol by volume. Light beers have 2 to 4, and malt liquors have 6 to 8. Then wine. Wine is popular and ancient. Standard wine is 14%. Fermentation is continuous, therefore older the better, because it keeps fermenting in itself. So older the better, and more alcohol content. Sparkling wine, essentially champagne, has a concentration of 10 to 12. Instead of water, it has soda. That is the only difference between basic wine and champagne. That is, water is converted into soda, and that is it. And you hype the price by 10 times. Some wines are fortified with distilled alcohol, so port, sherry, these things. Then what are your distilled alcohols? Gin, which is made up of juniper berries. They might ask this, huh? They used to ask what is made of what. I don't know why they did that, but still. So gin is made up of juniper berries, and it is 35 to 55%. Brandy is nothing but distilled wine. It is 35 to 60. Whiskey is made from distilled fermented grain, that is beer, and that is 40 to 50. Rum is made up of sugarcane, 40%. Tequila is made up of Mexican agave plant, that is 40%. Vodka is made up of fermented grains and potatoes, 40%. Then you have country made liquor, obviously, which is legal and illegal both. It usually has 28.5 to 42.5. It is made up of wheat, rice, kaju, that is cashew, and toddy is something that you find in India. Now, how do you calculate units of alcohol? 1 unit of alcohol is 10 ml or 8 grams of pure 100% alcohol. It takes an adult around 1 hour to process 1 unit of alcohol so that there is none left in the bloodstream. How do you calculate alcohol blood volume? 4% or 40%. Number of units is equal to alcohol by volume, alcohol by volume into volume, that is the volume of the bottle in ml, divided by 1000. Example, 750 ml of 11% alcohol by volume is 11 into 750 divided by 1000, which is essentially 8.25. Low risk drinking is 14 units per week. Severity of alcohol dependence questionnaire, SADQ, total score 60. Mild is 15 or less, moderate is 15 to 30, severe is more than 30. Seizure, maximum chances 12 to 18 hours after the last drink. Delirium tremens, usual onset is in about 3 to 4 days after the last intake, develops in 5% of total individuals, 10 to 20% mortality. Core symptoms of delirium tremens: clouding of consciousness, hallucinations, and marked tremors. Autonomic nervous system hyperactivity, insomnia. Treatment is benzodiazepines, benfotiamine, and haloperidol. Anti-craving drugs, the doses: acamprosate more than 60 kg weight, 666 TDS, less than 60, 333 TDS. Naltrexone start with 50. Disulfiram start at 800 and then reduce. Baclofen 10 to 20 TDS. In opioid, naloxone should be given 400 micrograms intramuscular. Varenicline dose is 0.5 milligram OD to 1 milligram.